So, Dr. Bari, I appreciate the opportunity to meet with you at least through this um, YouTube video. I apologize for not being able to meet with you in person, but due to recent events in the Middle East, my university and my wife insisted I not travel to your country at the current time, although I do plan to come in person as this project develops. My name is Ken Moise. I'm a professor of OBGYN and a professor of pediatric surgery at McGovern School of Medicine in Houston, Texas, United States. And I also work at the Fetal Center at Children's Memorial Hermann Hospital in Houston. I've spent the better part of my 30-year career talking about and doing research about rhesus alloimmunization and its effects on the fetus and the newborn. In the United States, about 85% of individuals are Rh positive and 15% are Rh negative. That is, they lack the D antigen on their red blood cells. In Pakistan, it was felt that in the past that about 93% of individuals were Rh positive and 7% Rh negative. But recent data from a pilot study done just this year in the Dadu district of Pakistan by Toronto Sick Children's investigators showed that the rate of Rh negativity is actually much higher at 17%, making the rate analogous to our U.S. population. The problem, of course, is that in the first pregnancy, if a woman carries an Rh positive fetus, because that particular fetus inherits its blood type from its dad, then at the time of delivery, some of these blood cells can escape into mom's circulation. These are recognized as foreign to the mother. So she develops antibodies to these. These, of course, don't affect the first child because it's been born, but in the next pregnancy, if she goes on to carry another Rh positive fetus, these antibodies can cross the placenta and attach to the red blood cells and cause their destruction. So the consequences of these antibodies is called hemolytic disease of the fetus and newborn, and it's these increased antibodies which are lifelong. They never really go away once they're formed. That can cross, as we mentioned, to cause fetal anemia, and in worst case scenario, heart failure and hydrops fetalis, and go on to cause fetal death. In the United States, this was not an uncommon problem. If you look back in 1960, about 1 in 167 pregnancies were affected by this disease. And in 1968, two investigators from Columbia University in New York came up with an injection called rhesus immune globulin, and after some clinical trials, they began to administer this to all postpartum women, Rh negative women delivered Rh positive babies, and you can see the incidence of rhesus disease has fallen dramatically to where we have stopped recording the incidence as of 1990 in our country. The injection is a simple injection. It's 98% effective when given at the right time and in the right amount. It has to be given at each delivery because it wears off, if you would. It's not a vaccine, it's an immune globulin, but it's very safe and has not been associated with any infections or consequences. This paper, published in 2011, looked at the burden of rhesus disease, particularly targeting Pakistan. At the time, in 2008, using UNICEF data, there were over 5 million births, and they used the 7.5% literature rate of Rh negativity, so that 298,000 pregnancies were at risk. They knew that only 36,000 units of rhesus immune globulin had been purchased by Pakistan, leaving 250,000 women untreated, and the potential for 17,000 affected fetuses and newborns. If we use the more recent incidence of Rh negativity, you can see the numbers are dramatically increased on an annual basis to where as many as 60,000 children could be affected either as fetuses or newborns. This is hydrops fetalis. This is a death of a second trimester fetus. You can see the ascites and scalp edema, which results in stillbirth. In the pilot study I mentioned in Dadu district, there were 1,619 women enrolled, 17 had stillbirths and 27 had neonatal deaths. Now, we don't know if all of these were related to rhesus disease, but clearly rhesus disease makes a contribution to this rate of stillbirth in your country. If we look at the WHO statistics from 2016, we realize that Pakistan, unfortunately, has the highest rate of stillbirth of any country reported in the world. And again, although rhesus disease probably doesn't cause all of these stillbirths, it probably makes a major contribution. We know from the pilot project in Dadu district that there is point of care testing with drops of blood that can be taken by healthcare providers in the field to do blood typing, so that very simply one can determine if the patient is Rh positive or Rh negative. That study showed that these healthcare workers very easily implemented this test. It was well accepted by the patients. So our proposal is to, and we have the support of Dr. Salim Khan and the Khan Foundation and Dr. Farhan Isa of the Isa Laboratories of Pakistan to help us with this. But our proposal is to create two different arms to this, to address this disease. The first would be a prophylaxis arm, where Rh negative women who are first time pregnant, so we know they don't have antibodies, would be given rhesus immune globulin at the time of delivery, which again would be 98% effective. In the treatment arm, we would look for Rh negative subsequent pregnancies. We would screen them for antibodies. If there were no antibodies, they again would get rhesus immune globulin at delivery. But if antibodies were present, we would be interested in developing a program for treatment by working with local Pakistani physicians at your hospital to attempt to develop a protocol for both monitoring and treatment at the hospital. One of the main goals of this would be to teach physicians and sonographers at your center how to do the middle cerebral artery. That's actually a test I helped develop in the United States, where we can use specialized ultrasound to measure the speed of the blood in the cerebral circulation of the fetus. And based on normative values, we've determined that if the speed is more than 1.5 times normal for gestational age, this is indicative of fetal anemia without any need for amniocentesis or other tests. This is just a graph showing that line of 1.5 multiples of the median in a particular patient we followed with serial values in ultrasound in a non-invasive fashion. And when we finally did do cortocentesis or pubs at about 29 weeks, the baby had a blood count of 26%, which was just barely anemic. If we look at procedures to treat the fetus on intrauterine transfusions, this is the largest series out of Belgium. And you can see, if we look at their more recent data of 900 pregnancies or procedures, they had a 97% success rate for their pregnancies with a procedure-related complication rate of about 1.2% and a loss rate per procedure of only 0.6%. We do know there's a learning curve to this. This again comes from the group in the Netherlands, who showed us that it takes about 35 to 50 procedures per doc to learn how to do these in a very competent way and get good outcomes. So this is totally teachable with the proper equipment, and this is something I've been doing for 30 years and we would be happy to share with Pakistani physicians. The cost of this program would not be incredibly expensive. The GE machines, the E10 machines, which are the newest version machines, run about $98,000 a piece in Pakistan. A Coulter counter, a portable counter where we could do a blood count right outside the operating room would be about $10,000, and then a supply cart would be about $5,000. And again, with the support of the Khan Foundation and perhaps a Gates Foundation grant, maybe even a National Institutes of Health grant, we would want to set up a pilot program to train physicians once we had all the proper equipment in place. So that's kind of our concept. I do have some questions I'd like to send your way, and maybe Dr. Ajax could take some answers for me. But maybe the first question would be, how many deliveries do you do at your institution at Indus? What percent of your patients get some form of prenatal care, and when does it typically start? In other words, when do they first come in at their first booking visit? What percentage of your OB patients get an ultrasound, and what are your ultrasound capacities at Indus? How many different clinics feed into Indus, into your main hospital, into your OB service? What's the general knowledge of the obstetrical community regarding Rh disease and its treatment and prevention? And are there any national guidelines that Pakistani physicians follow regarding the prevention and treatment of rhesus disease. And finally, to be more specific, do pregnant women in your system have a blood type done at the first prenatal visit? Is that part of their routine evaluation? And is rhesus immune globulin even given either at 28 weeks of gestation or at delivery as a routine at your hospital? And finally, is cord blood routinely obtained at the time of delivery by the delivering healthcare provider to determine the baby's blood type? So those would be my questions, and maybe Najma could jot down some of those answers as we start this fact-finding mission to see how we could put a project together. Again, I am sorry I'm not there in person, but I appreciate the opportunity to present this to you with the hopes that we can work together collaboratively in the future. But thank you very much.